Hello. In all my time of giving talks about this subject, I've learned that I need to provide a trigger warning. I will be sharing infant pictures, family stories, and parent quotes that may be sensitive, and sad feelings may hit you in a way that are not expected. I invite you to do what you need to do to honor those feelings. Please know that while this is a hard topic to think about, opportunities do exist to support families and give them hope. Today, I share with you the building of a neonatal palliative and end-of-life care program. Each year in the United States, approximately 10% of all live-born infants are admitted to the NICU. Even with a focus on stabilization and survival, about 16,000 of them, or 44 infants a day, will still die in NICUs around our country. This accounts for the highest death rate of any hospitalized pediatric group. Further, infants who survive the NICU often experience complex chronic conditions that qualify them for palliative care. And although these children account for less than 1% of all U.S. children, they account for an estimated 30% of all pediatric healthcare costs. And in the past decade, hospitalizations for children with complex chronic conditions have increased nationally by 33%. The cost of infant illness is magnified when you consider the downstream effects on all the parents, grandparents, siblings, extended family, friends, and the healthcare team who love those babies and care for them. I didn't set out to do this work. I happened upon it and couldn't turn away. This calling came together like pieces of a puzzle. As an undergraduate student, I saw an infant placed on a warmer and left alone to die. No one held the baby, no one advocated for the mom to stay, and no one could answer my questions. During my neonatal nurse practitioner clinicals, end-of-life care was begun while a baby was still alive. At least for that baby, my questioning led to a change in care. As a new staff nurse, my patient Hope acquired an ultimately fatal infection. I could barely provide care for her, let alone help support her mom. But fortunately, I was working with an expert neonatologist who led the way, and following her death, we participated in her twins' baptism during an evening that continues to be the most profound of my nursing career. Mom Leslie taught me about honoring life and legacy building following the unanticipated and tragic loss of her son, Aiden, from an anoxic event that occurred at delivery. Final pieces of the puzzle fell into place when, as a more seasoned nurse, I had the privilege to care for Claire. Her parents were not afraid of difficult conversations. They asked hard questions and made courageous decisions for their daughter. And even though her death was not the outcome they were praying for, her parents were satisfied with her care and felt comfortable that everything that could have been done was done to try to save her life. But I knew that not all families felt this way. And still other families like Drake's were ending one leg of a long NICU journey, but starting another leg that was filled with even more uncertainty and doubt about the future. Their ability to face challenges head-on could directly affect the care that their child would receive. These experiences, along with initial pilot work, culminated in the development of a framework to evaluate quality of care. This model that continues to evolve has driven my research to date. We have learned that infants experience different illness trajectories and that we are largely unable to predict when or if they might die. They are also treated inconsistently in an environment that is uncertain, uncomfortable, and often chaotic. Parents have told us that they are distressed by the appearance of their infant and the symptoms and suffering that they witness. Their perceptions of their infant's well-being influence their decision-making and their long-term mental health outcomes. Some parents struggle with post-traumatic stress and prolonged grief, even if their baby survives. Parent mental health and well-being outcomes are so important that the U.S. Surgeon General has recently elevated these to a national priority. Parents have told us that they want us to be better communicators, to improve upon the anticipatory guidance and bereavement care that we deliver, as well as to provide the best symptom management possible for their infants to mitigate suffering and improve quality of life. But this isn't as easy as it sounds, because little research has focused on infants. In fact, children under 2 are often excluded from symptom and medication research because they are too different from older children. Assessment tools for symptoms other than pain remain unavailable for this population. Pain assessment tools are not validated for use at end of life or for palliative care settings. This has left significant gaps in our understanding of the experiences of severely ill infants. We must identify the key factors that influence how parents and healthcare providers learn and communicate about infants in order to promote health and prevent negative long-term health outcomes. For example, how do social determinants of health and provider bias influence care delivery in the NICU? White male infants, often called wimpy white boys, often receive excessive treatments, while Black infants experience higher rates of mortality. Clinician implicit bias is reported to affect team communication, patient referrals, and maternal attachment in minoritized groups. These differences in care are based in stereotypes. We must gather the evidence that is needed to treat all infants exactly how they should be treated for their unique illness presentations. My research seeks to identify all the factors that influence the quality of infant and parent experiences, no matter whether they die or survive with a complex chronic condition, all so that ultimately interventions may be developed. Interventions are needed to reduce infant suffering and improve quality of life, to lessen parent distress and improve coping, and to increase parent resiliency to move forward following the loss of their infant child, or to provide long-term care for an infant with complex care needs. We can do this by learning about families, by teaching healthcare providers, and by developing better assessment tools and supportive programs. In one of our studies, a bereaved mom said, "I've grown more, and at the same time, I am still me and just have a different understanding and outlook on life. And I think that I feel good. I have my moments, but for the most part, I still have joy." My calling to care is to discover how to ensure that all families feel this way following a NICU stay, no matter the outcome, while delivering them hope for the future. Thank you.